Okay, everyone, I think it's just now a minute after, so we'll go ahead and get started for today. So welcome everyone to our NCS Pharmacy Section Journal Club for December. My name is Colleen Barthol, and I'll be your moderator for today's session. We have additional moderators, Devin Holden and Kimberly Lavasser Franklin, who will be assisting. And we'd like to thank our Journal Club coordinator, Corinne Berger, as well. So just quick reminders before we get started. For everyone who's on the session today, please remember to mute yourself if you're not speaking, and follow along on our Twitter with the hashtag NCSPharmJC for Journal Club. So today I'm very happy to introduce both of our speakers, Sarah and CJ, and we'll start with Sarah. Sarah Berman is a PGY2 critical care resident here at University Health in San Antonio. And today she will be presenting her journal club, and I'll let her introduce her title.
All right, hello everyone. Let me get my screen shared for you. Is it showing up okay?
Yes, looks good, Sarah.
Okay. All right, well, thank you so much for that introduction. As Colleen said, my name is Sarah Berman, and I'm currently a PGY2 critical care pharmacy resident at University Health in San Antonio. Today, I'm excited to share with you the DEX-CSDH trial, which is the largest trial to date regarding dexamethasone in the management of chronic subdural hematoma. I know a lot of us might have some strong opinions about the use of steroids in this setting, but I'm hoping by the end of this presentation that we'll have some good tools in our tool belt to be able to discuss this in the management of our patients. So my objectives today will be to briefly review the pathophysiology and management of patients with chronic subdural hematomas, and then we'll spend the majority of our time discussing the results of the DEX-CSDH trial and how this applies to clinical practice. Looking at a background of chronic subdural hematomas, we first need to note where they're located. So these tend to form between the dura and arachnoid membranes, which you can see pictured here on the right. Diagnosis happens through non-contrast CT scans, and that is pictured in the middle there for you. We can recognize it based on a classic crescent shape. And in a chronic subdural hematoma, these will appear as a hypodense, isodense, or mixed density lesions, as opposed to the hyperdensity that we see in an acute bleed compared to the rest of the brain. Subdural hematomas are incited by some type of vascular injury, whether that be traumatic or non-traumatic. And in a chronic subdural, we have this following process of blood breakdown and neomembrane formation that potentiates further bleeding. Within this process, there is inflammation and remodeling happening that, again, is going to potentiate the formation of this bleed. In presentation, it's important to note that symptom onset is very late in a chronic subdural hematoma, happening at least 21 days after the initial inciting incident. The symptom onset is usually pretty gradual, with things as mild as a mild headache, all the way up to seizures and even coma, depending on the size of the bleed. We often think of chronic subdurals as a disease of the elderly, and this is very uncommon in patients less than 60 years old. There's a highly increased risk with cerebral atrophy, which of course occurs naturally as we age, but is also occurring in patients with alcohol use disorder, as well as neurodegenerative diseases such as dementia. Some of the other strongly associated risk factors include coagulopathy, as well as antithrombotic use, which can be antiplatelets or anticoagulants. Incidence has been rising over the past several years, and it's predicted to continue to rise as our population continues to live longer and longer. Not only is a rising incidence a problem, but we also see that these patients have a high risk of recurrence, with up to 20% of patients experience recurrence after surgical evacuation. In thinking about subdural management, we know that the most definitive treatment is surgical hematoma evacuation, which can occur through things such as a burr hole or mini craniotomies in more severe cases. In acute subdural hematomas, we know that surgical evacuation is indicated with a maximal thickness of at least 10 millimeters on CT scan or a significant midline shift. And we often apply this to chronic subdural management as well. However, in chronic subdurals, we can consider non-operative management if there are limited symptoms, as long as we observe those patients carefully. And this makes sense because you think of this elderly population, it's often not ideal to perform a surgery. Based on the desire to guide a patient towards non-surgical management, there's been a lot of interest in looking at different pharmacotherapy to see if we can manage a patient medically. However, so far, there really hasn't been a lot of success with that, and we've looked at numerous classes of medications, including statins, TXA, and corticosteroids, which is where we're going to focus today. Corticosteroids have a theoretical benefit given the potential role of inflammation in chronic subdural formation. Increased inflammation caused by that acute bleed will cause the neomembrane formation and remodeling process, and it also stimulates the growth of these frail neocapillaries that can stimulate more bleeding. Dexamethasone has been the most commonly studied, but the use of steroids is really controversial in this setting given the outcomes that we've seen in other types of intracranial hemorrhage. The Brain Trauma Foundation has actually given a recommendation to not use corticosteroids for the purpose of reducing intracranial pressure, and this is a level 1 recommendation. They give this recommendation based on the findings of increased mortality in patients with severe TBI when steroids have been utilized. However, we have looked at steroids in chronic subdurals in multiple studies, but the evidence has been pretty limited. So let's take a look at what is available so far. Again, the interest in using medical therapy often comes from the desire to avoid surgery in these elderly patients. So these first 2 studies look at the use of steroids in this setting. Prudhomme and colleagues was published in 2016, and this was a randomized control trial that looked at 20 patients who had imaging-confirmed chronic subdural hematomas. They were randomized to either 3 weeks of dexamethasone at a dose of total 12 milligrams per day, and then followed that by a 1-week taper compared to placebo. Within this study, there was no significant difference in conservative success, which was defined in the study as avoiding surgery as well as experiencing no serious adverse events. There was also no significant difference in the requirement of surgical intervention, with 1 patient in the dexamethasone group requiring surgery and 3 patients in placebo. Not surprisingly, we saw that adverse effects were significantly worse with dexamethasone at 30 days. However, this trial was pretty small, so even though we didn't see a benefit, it's important to look at it in a bigger patient population. So next, I'd like to discuss the DEXA-R study, which did give us that larger patient population with 120 patients, but it was retrospective in nature.
It's like a...
The dexamethasone was...
I think that might be the jalapenos.
Sorry, I think someone's unmuted. All right. So the dexamethasone cohort received doses of 3 to 4 milligrams twice a day.
Just have your jalapeno.
Compared to a burr hole craniostomy alone. Within this study, they saw that there was no significant differences in functional outcome, which was defined as a modified Rankin score of 0 to 3. And they also saw that there was no significant differences in recurrences. Another thing I'd like to point out here is the rate of surgery with dexamethasone was still 83%. So we really didn't see any benefit of dexamethasone in helping avoid surgery. But what about in addition to surgery? Could that help us prevent that recurrence that's such a problem in this patient population? These 2 studies looked at this issue, and the first was published in 2015, looking at 248 patients, and this was a randomized control trial. Patients received burr holes as the method of evacuation, and 1 group received dexamethasone while the other received placebo. There was no significant differences in rates of recurrence, favorable outcomes, or adverse effects within this trial. But the Meberson study that was published recently in 2020 found something a little bit different. So this randomized controlled trial made up of 47 patients, had a similar design with patients receiving dexamethasone with surgical intervention compared to surgical intervention alone. And in contrast to the previous study, we saw that there was a significant reduction in recurrence with dexamethasone, with none of those patients requiring any surgical intervention after recurrence. There was also no difference in mortality, modified Rankin score, or adverse events. And so we see that we have some contrast in the literature, and that is really where this study came in that we'll be discussing today, kind of trying to formalize how we evaluate these patients in a better study design. So we're going to move into the DEX-C-SDH trial. And the primary question that they were hoping to answer was, does dexamethasone improve outcomes in patients with chronic subdural hematoma at 6 months? This study was a randomized double-blind placebo-controlled trial, and it was a multi-center trial completed in 20 centers in the UK. Clinical decision-making for surgical evacuation versus conservative monitoring and not going to surgery was made by the treatment team and was really not dictated by the study at all. Patients were randomized in a 1-to-1 ratio using permuted block sizes of 2 or 4. Patients were included if they were 18 years or older and had CT confirmed chronic subdural hematoma presenting in a symptomatic fashion, and they were excluded if they were unable to receive corticosteroids. This included patients who had an active systemic infection, a recent peptic ulcer, or GI bleeding. They were also excluded if they had received glucocorticoids within the past month and if they had a history of CSF shunt or psychotic disorders. Additionally, patients also had to receive the first dose of the study medication within 72 hours of admission. Patients were randomized to an oral dexamethasone taper or matching placebo, and you can see the taper illustrated on the screen here for you. The patients were started at a dose of 8 milligrams twice a day for the first 3 days and then tapered over the following 2 weeks. Dexamethasone tablets were encapsulated in a capsule, so the matching placebo was the capsule that contained the dexamethasone tablet. This did create some opportunity for unblinding because if a patient was unable to receive oral medications, the capsule could be open and administered via NG tube, but if it was a placebo capsule, the capsule was empty. Because of this, the nursing staff did receive some training about how to hide this from the patient as well as provider team to try to maintain that blinding. The primary outcome in this study was a favorable functional outcome, which was defined as a modified Rankin scale score of 0 to 3 at 6 months after randomization. And this is very similar to what we have seen in the literature thus far to date. The modified Rankin scale is a score that's often used in patients after stroke, and it signifies the amount of disability. So it's on a score of 0 to 5, with 5 signifying severe disability. A score of 3 is someone who has moderate disability, but they still maintain the ability to ambulate independently. And so this is seen as a favorable outcome in patients post-stroke. In the secondary outcomes, they also followed that modified Rankin scale at discharge and 3 months, as well as mortality. They looked at the number of surgical interventions that were required, as well as quality of life scores like the Barthel Index score and the EuroQoL Group 5 Dimension Questionnaire. Additionally, ICU length of stay and discharge disposition were followed, and adverse effects were of special interest to the authors as well. Finally, a tertiary outcome that we'll discuss in a little bit is the recurrence of evacuated subdural hematomas. As I mentioned, the authors did want to look at some adverse events of special interest, and you can see these detailed here on the screen. They're some of the more serious things that we think of with steroid use, such as hyperglycemia, new onset mood disorders, and GI bleeding. The statistical analysis plan of the study was actually published separately, but I do have it detailed on the next 2 slides for you. The power analysis that was completed prior to the trial beginning said that we needed a sample size of at least 750 patients, and this was assuming a loss to follow-up of 15%. 750 patients would provide power to detect a treatment difference of 8% for the primary outcome. An interim analysis was also planned after 450 patients had completed 6 months of follow-up, and this was to determine if the sample size would be adequate for that treatment difference. Additionally, the authors used a modified intention to treat analysis, and this included all patients except for those who withdrew consent or were lost to follow-up at 6 months. In analyzing the primary outcome, remember that this is a favorable MRS score of 0 to 3 at 6 months. And they did this by estimating the absolute between group difference using a normal approximation. A normal approximation is a test that is able to be used when one of your outcomes is considered a success and one of the outcomes is considered a failure, and it uses the least amount of assumptions possible. So it's good for outcomes that are expected to have a low event rate. Secondary outcomes were analyzed with a proportional odds, linear, or logistic regression as indicated, but I will say that this was done without adjustments for multiple comparisons. A sensitivity analysis was also performed in the per protocol population, and this included only patients who received at least 80% of the study drug doses, and it excluded patients in the placebo group who received more than 8 milligrams of dexamethasone. Several exploratory analyses were also performed, and this looked at pre-specified subgroups such as study site and patients with bilateral chronic subdurals. Patients were recruited over a 3-year timeline, and ultimately 750 patients were enrolled. 45 withdrew consent, and then 23 were lost to follow-up. So this left for 680 patients to be included for analysis. Getting to know our patient population a little bit, it's not surprising to see that our mean age here was about 74, as we know this often occurs in an older population. About 70% of patients had some type of known head trauma in the past, and about 45% were on some type of antithrombotic medication at baseline. The severity of presentation was pretty equal between groups, as we can see with similar MRS scores and a similar presence of midline shifts. I will say that more of the placebo group were independently mobile at baseline, and more of the dexamethasone group were on warfarin compared to the placebo group. All right, so jumping into our outcomes, this is our primary outcome, which again was a favorable modified Rankin score of 0 to 3 at 6 months. This figure here on the right depicts this outcome at discharge, 3 months, and 6 months. So 6 months is our primary outcome, and that's all the way over on the right. The blue colors here represent a favorable outcome. And so what we saw was that dexamethasone actually had less favorable outcomes than placebo at 6 months. This resulted in an absolute percentage difference of negative 6.4%, and this was statistically significant. A logistic regression was also performed to adjust for age and GCS at presentation, and the hazard ratio there was 0.55, again in favor of placebo, and it was statistically significant. Looking at our secondary outcomes, there were no significant differences in the patients who required operation during the primary or subsequent admissions. We did see that there was a numerically higher rate of mortality at 30 days, but this did not persist through 6 months. Again, I want to remind you that the secondary outcomes were not adjusted for multiple comparisons, so we have to be very careful with how we interpret any of the odds ratios where your confidence interval approaches 1. Looking at the rest of our secondary outcomes, we see that there was no significant difference in the modified Rankin score at discharge, but we did see that there was a significantly higher amount of patients who achieved a favorable outcome at 3 months in the placebo group, which we already know persisted through that 6-month mark. However, more patients in the dexamethasone group were able to avoid any recurrence, and so that's something to note as well. However, we really got to ask ourselves, okay, we see these primary and secondary outcomes, but did dexamethasone do harm in terms of adverse events? Unfortunately, the individual adverse events were not specifically reported by the study. They only represented them graphically in the supplementary appendix. The only one that they specifically reported the incidence was infections. And here we see that infections were numerically higher in the dexamethasone group. However, in both the adverse events of special interest and those considered serious adverse events, this was statistically increased in the dexamethasone group. Based on this study, the authors concluded that treatment with dexamethasone resulted in less favorable outcomes at 6 months compared to placebo, and there was a statistically significant increase in adverse events. Additionally, we do need to note that there were less repeat operations in those patients who took dexamethasone based on decreased recurrences. So before we really jump into how we apply this clinically, I think it's important to think about the strengths and limitations of this study. So we see that this was a randomized double-blinded study design with the largest sample size to date of the trials that we have regarding dexamethasone use in chronic subdural hematomas. Additionally, it allowed for a pragmatic approach with real-world surgical management where the surgeons and treatment team were able to decide whether to take the patient to surgery or not. There was also excellent follow-up rates with a 9% loss to follow-up, and they did confirm study drug adherence through the return of medication pill packs to those patients who had been discharged prior to that 14-day mark of the dexamethasone taper. However, the study did have several limitations that I think are really important to consider. There were approximately 90% of these patients in both groups underwent evacuation. And so this really makes the study an evaluation of surgery plus adjuvant dexamethasone. We really aren't able to make any conclusions about whether dexamethasone can be used as a primary treatment. And that's often where we are interested in using it to avoid surgery in this elderly population. Additionally, there was no pre-specified plan for adjusting confidence intervals for multiple comparisons, which really limits the conclusions from the secondary outcomes, as we might have just found a difference because we were looking for one. Finally, the incidence of specific adverse effects were not reported in the study or in the supplementary appendix, which is unfortunate given that we did see such a significant increase in adverse effects. So overall, what can we use this study for? I think it's important to note that surgical intervention alone without dexamethasone at all resulted in a favorable outcome in about 90% of patients. And the patients who did receive dexamethasone had a significant increase in adverse effects. Based on the results of this study, I think we can be comfortable in saying that dexamethasone should not be routinely recommended for patients who present with chronic subdural hematomas. It's possible that the poor outcomes that we saw with dexamethasone are likely related to the significant increase in adverse events. At my own institution, there are some providers who will use dexamethasone in patients who have severe neurological deficits that persist after surgery. And based on this study, I would argue that maybe we need to change that practice in considering that dexamethasone actually worsened the functional outcomes at 6 months compared to placebo. One area that this study did show benefit, and this is consistent with the previous Meberson study, we saw that there was a decrease in recurrence in patients who received dexamethasone. And so this might be a consideration, although I would say with caution in those patients who have recurrence after evacuation. However, I think there are a couple areas that we still don't have answers with dexamethasone in the management of chronic subdurals. So as I mentioned before, we're often interested in trying to avoid surgery in these patients, and we don't have answers yet to whether dexamethasone can be used as an initial management strategy rather than going straight to surgery. In the future, if we're going to continue studying dexamethasone, I think we could consider lower doses or durations, as all of the studies that we have thus far are pretty long durations of weeks of dexamethasone. But I would say we need to do any retrials with caution, as we saw some pretty poor outcomes in this trial, especially when you consider the potential increase in mortality. Any future trials, I think, need to have very carefully planned interim analyses to be able to assess the safety of the study drug. Additionally, while I mentioned that maybe we could consider dexamethasone in patients after recurrent chronic subdural hematomas, we really haven't studied that patient population. So this is yet again another area where we would need some more evidence. So with that, I would like to thank you for the opportunity to present today, and I would be happy to take any questions or comments. Looks like I have one or a couple questions coming in the chat. So the first question is from Karen Berger, and she said, how can we extrapolate this data, if at all, to acute or acute on chronic subdural hematoma? I think it's pretty difficult to extrapolate. There was a pretty hard exclusion of excluding acute subdural hematomas. They did have a mention of what to do with acute on chronic subdural hematomas. So they did allow for the inclusion of patients with up to a 15% hyperdense lesion on CT. So that would be your acute on chronic. So those patients were included in this study, but again, I would still encourage us to avoid it if at all possible. We've seen in other types of hemorrhage that we really shouldn't be using steroids. And so I would say that we should be doing that very much with caution, but it is difficult to extrapolate, especially to purely acute or traumatic subdural hematomas. And then the second question is a great question. It says, did the authors assess or control for the use of statins in this study? And unfortunately, I didn't see anywhere that they even recorded a history of being on statins, which I think is interesting. There are several studies that have come out recently that have actually shown some positive associations with statins in reducing recurrence and avoiding surgery. So I think that would definitely be an important area to control for. Unfortunately, they didn't even record the patients that were on it. But I was interested to see, I was expecting statins to have pretty limited effects, given that we usually think of them as a more long-term benefit, but we actually did see in some recent studies some potential benefits. So I think that's interesting.
Thank you, Sarah, for that excellent presentation. I have a quick question for you about your considerations with using a lower dose or a shorter duration. Do you have something in mind that you would recommend if you were asked about that?
Yeah, I think that's an interesting thought. The lowest that I really saw was similar to what this study did, the 4 milligrams Q6. I think we could consider, there were some studies that used a total of 12 milligrams. So that would kind of be my first cap. And then the thought process behind duration, I think, is difficult because your highest risk for recurrence is in that first 2 weeks. So these studies that go much past 2 weeks, I really struggle with that idea. So I would definitely try to limit to 2 weeks. At my current institution, we often only do 1, although again, I don't know that the practice that we're using steroids is appropriate in most patients at all. But I would definitely limit to 2 weeks. And if we can get away with less than that, I would say probably the lowest I would go is 10 days, just based on the pathophysiology of when the risk of recurrence is. I'm not sure a week is long enough if we're really using it to try to prevent recurrence. If it's thought to be more for a neurologic deficit, maybe you could say you could go less, but if you're aiming at recurrence, I think at least 10, no more than 14 would be my answer there.
Thank you, Sarah. Are there any other questions? Either, feel free to unmute yourself and ask your question or type it in the chat.
I have a quick question. This is Devin Holden. Do you think would be worthwhile or ethical to do a study assessing dexamethasone to avoid surgery in this population? Or do you think the data is that would not be in the best interest of patients, given the potential risks?
Yeah, thanks, Devin. I struggled with that question because I think it is difficult to say that you would be willing to randomize a patient to not going to surgery when we know that is the definitive treatment. I would struggle with designing a randomized controlled prospective trial that way. I think the only way that we're really going to be able to assess that is a retrospective review of those patients who were not able to go to surgery. And again, that's going to be flawed just in the sense that those patients are probably better off in general. So I don't think it's a study that we should probably be pursuing actively. But I do think any cases of being able to assess that retrospectively are worthwhile, given that we do need some options for those patients who are much older and might have comorbidities that prevent them from going to surgery. And then another question in the chat, do we know for sure that surgery is the definitive treatment? Likely some patients in a gray area where we don't know. Yeah, that's kind of where I was going with that. I think there's some patients who maybe don't need that, or if they don't progress any further, there's some data in some different studies that I looked at that maybe dexamethasone could help prevent progression. So I think that that is the issue that where we might be using dexamethasone instead of surgery. And there are also some novel options like using MMA embolization or middle meningeal artery embolization to try to stop that bleeding. So that's another area where we could be avoiding surgery in a different way compared to using steroids, where we know they might have some significant adverse effects. And I think that could be an emerging option that is better than dexamethasone.
Are there any other questions for Sarah? Okay, well, if not, then we will move on to our next presenter. Thank you, Sarah. That was excellent.
Thank you.
So our next presenter, while he's loading up his slides, is CJ Wilson, and he is a PGY2 critical care resident at Wesley Medical Center in Wichita, Kansas. And go ahead, CJ.
All right, can you see my screen and hear me all right?
Yes, everything looks great.
All right, thank you for joining us today. Like mentioned, my name is CJ Wilson. I am a PGY2 critical care resident at Wesley Medical Center. Today I'll be discussing the RESTART randomized clinical trial, which evaluated the effects of antiplatelet therapy after stroke caused by intracerebral hemorrhage. Throughout this presentation, I hope we can review current recommendations for restarting antiplatelet therapy post-hemorrhagic stroke, examine the design of a randomized open-label trial evaluating the resumption of antiplatelet therapy, and discuss the implications of this study's results on clinical practice. As we know, most patients get initiated on antiplatelet therapy to reduce the risk of ASCVD events, whether that be primary prevention or secondary prevention. Once we place these patients on antiplatelet therapies, that increases their bleed risk, and in some instances causes a intracerebral hemorrhage. In the majority of these patients, after their intracerebral hemorrhage, we remove the antiplatelet therapy from their medication regimen, which may increase their ASCVD risk once again. And the question remains whether or not it's safe to restart that antiplatelet therapy and whether or not that is beneficial for the patients. To further understand the risk that's seen post-intracerebral hemorrhage, there was a pooled data set of approximately 675 patients that looked at 1,500 patient years, evaluating the rates of different events post-intracerebral hemorrhage. As you can see, that there is a risk of recurrent hemorrhage at a rate of approximately 3.2 per 100 patient years. However, you can also see that the rate of serious vascular events in this patient population is higher at almost 8 events per 100 patient years. Because of this increased risk, the current guidelines recommend aspirin monotherapy may be considered for antiplatelet therapy in patients who have experienced an intracerebral hemorrhage. However, if resuming aspirin, the timing of that resumption is uncertain. These recommendations come from mostly non-randomized data from retrospective trials that have some conflicting results. And I want to go into these data points a little bit more. One of the major meta-analyses that evaluated the benefits of aspirin therapy in patients who have had some sort of intracerebral event was conducted by the Antithrombotic Trialist Collaboration. This meta-analysis was focused on both primary and secondary prevention using antiplatelet therapy. However, I am going to be focusing on the results of the 16 secondary prevention trials that looked at aspirin versus no antiplatelet therapy in patients who had experienced a myocardial infarction, stroke, whether that be ischemic or hemorrhagic, or transient ischemic attack. In the patients that were looked at in this meta-analysis, the outcomes that they evaluated were serious vascular events, which incorporated both major coronary events and stroke, whether that be ischemic or hemorrhagic. And they also evaluated deaths that were from any cause in these patients. These investigators found that there was a statistically significant decrease in risk of serious vascular events in a patient taking aspirin as monotherapy and compared to patients not taking aspirin. However, they did not find any difference in death from any cause in these patient populations. It's important to know that this was a composite outcome that looked at major coronary events and ischemic and hemorrhagic strokes. So as you can see here, it seems that the majority of the driving factor of the statistical significance in that result was driven from the major coronary events, which mainly included myocardial infarctions, with a decrease in approximately 1% in the aspirin group versus the no aspirin group. However, when looking at both hemorrhagic and ischemic stroke, there was no statistical difference in the aspirin versus no aspirin group, which still leads to the conclusion that this information is not supportive of using aspirin monotherapy in all patients that have had some kind of hemorrhagic event. However, it could help inform clinical judgment on using aspirin on a case-by-case basis. Because this data was limited in the amount of patients that had intracerebral hemorrhage, the question still remains if it is appropriate to resume that antiplatelet therapy in this patient population, which led to the RESTART trial. The RESTART trial is the first and to date only randomized control trial that has evaluated antiplatelet resumption post intracerebral hemorrhage. It was a multi-center study that evaluated about 530 patients. To be included, the patients had to be at least 18 years old and survive a spontaneous hemorrhage while on antithrombotic therapy. Patients were excluded from evaluation if they had a traumatic brain injury, hemorrhagic conversion of an ischemic stroke, or intracranial hemorrhage without intracerebral hemorrhage. Once these patients were identified, they were randomized 1-to-1 into either a START antiplatelet group or an AVOID antiplatelet group. In the START antiplatelet group, investigators were instructed to start their patients on antiplatelet therapy within 24 hours of randomization. They could initiate aspirin, dipyridamole, or clopidogrel, or any combination of the three agents. And in the AVOID antiplatelet group, investigators were instructed to avoid antiplatelet therapy initially. However, if there was new risk identified in these patients, they could initiate antiplatelets at any point during the follow-up. Once these patients were identified, surveys were sent to both their primary care provider and the patient to report whether or not an outcome was met during this follow-up time. If the patient did not respond to the survey sent, patients received a phone call to ensure adequate follow-up. If the patient or primary care provider reported one of the outcome events, then reviewers were assigned to verify the outcome. The reviewers had access to all clinical information. They had access to imaging, medication history, and clinical notes. And the patients and primary care providers received this survey annually for up to 7 years in this extended follow-up survey. The outcomes that were being reported primarily was the recurrent intracerebral hemorrhage. And then secondarily, we were looking at major hemorrhagic events, which was defined as any bleeding event that required blood transfusion or resulted in death within 30 days. And major occlusive vascular events, which included acute ischemic stroke, myocardial infarction, mesenteric ischemia, or venothromboembolism. When looking at our patients between the two groups, you can see that they're fairly similar in sex, age, and race. They're also similar in the location of the bleed. I want to point out that about 60% of the patients had a supratentorial lobar hemorrhage. This is important to realize because lobar hemorrhages are associated with higher risks of rebleeding than other intracerebral hemorrhages. However, the authors did not include any information on other locations for hemorrhage, just the information seen here. Additionally, it's important to look at when patients were randomized since their hemorrhage. And as you can see, the majority of patients were randomized after 1 week since their hemorrhage, with almost 75% in both groups being randomized greater than 30 days post their hemorrhage. Additionally, it's important to look at what antiplatelet therapy was initiated or would have been initiated if indicated in the AVOID group. And you can see that the majority of patients were initiated on either aspirin or clopidogrel monotherapy, with very few patients being initiated on a combination therapy or dipyridamole monotherapy. When taking a look at our results of our outcomes between the two groups, you can see that there was no statistical difference in any of the three outcomes. There was no statistical difference in the recurrent intracerebral hemorrhage. There was no statistical decrease of risk of major hemorrhagic event, and no significant decrease of risk of major occlusive event in the START antiplatelet group versus the AVOID antiplatelet group. While there was no statistical differences, it is interesting to see that there was a numeric difference in the risk of major occlusive events. I do want to point out that, again, this was not statistically significant, and the numerical values do start to equilibrate further on in the study follow-up time. One major factor to evaluate is whether or not patients were adherent to their protocol that they were assigned to, since it was an option for patients in the AVOID group to start antiplatelet therapy if a new indication arose. In this graph, I have the START antiplatelet group in red and the AVOID antiplatelet group in blue, with the darker portions of the bars being representative of the patients that were adherent to their trial group, and the full bar being those that were not lost to follow-up. So as you can see, as the years went on, the majority of patients fell off from follow-up. However, you do see that there was a high rate of adherence to each trial group throughout the follow-up in both the START antiplatelet group and the AVOID antiplatelet group. Based off of these results, the authors concluded that there was no statistically significant increase for the risk of recurrent hemorrhage in these patients, and these findings provide reassurance that the use of antiplatelet therapy after intracerebral hemorrhage can be done in a safe manner. However, this study is not without its limitations. First, I want to point out that while this is represented as a 7-year follow-up time, the median follow-up time was approximately 3 years, with the interquartile range being 2 to 5 years. This is important because rebleeds and intracerebral hemorrhage can be seen as quickly as a year post-bleed, but as delayed as up to 7 years post-rebleed. So it is important to realize that the follow-up time was not as long as anticipated. The next limitation is that there was no standardized start time of the antiplatelet regimen. We can see from the baseline demographics that the majority of patients that were randomized from this trial were greater than 30 days post their hemorrhage. So the optimal reinitiation time of antiplatelet therapy still remains unknown. There was no standardized antiplatelet regimen designed for any of the patients, and there was no monitoring for response of these regimens. So it's unknown if a patient at the time of randomization was on a higher dose of antiplatelet therapy if they were restarted on a lower dose. We don't know if standard dosing was used for aspirin at 81 milligrams or 325 milligrams. It could have been done at the discretion of the investigator, which limits the generalizability of these results. Based off of the results and the limitations of the study, I feel like it's safe to say that there's no increased risk of recurrent intracerebral hemorrhage when restarting antiplatelet therapy. However, there seems to be no increase or decreased risk of occlusive events as well. These results show that there's likely no additional harm in resuming antiplatelet therapy. However, the methods for this trial do not give us a definite timeline for when restarting antiplatelet therapy is most ideal, and there needs to be further studies done to determine when the optimal time for resumption is, and to validate the results of this study. I want to thank you for your time, and now I can take any questions that you might have.
Thank you, CJ, for that excellent presentation. Are there any questions, either verbally or I don't think I see anything in the chat quite yet, but we'll keep an eye on that as well.
I do see a question from Karen that says, do these results apply equally to aspirin and dual antiplatelets based on the patients enrolled? And I would have to say that no, they do not represent both aspirin and dual antiplatelet, as the majority of patients were either started on aspirin monotherapy or clopidogrel monotherapy. There was only about 1% of the patients that were started on dual antiplatelet therapy. So I don't think that these results can help determine whether or not dual antiplatelet therapy is safe. The next question is thoughts on extrapolating any of this data to other antiplatelet medications, clopidogrel, et cetera. And about 40% of the patients in this trial were initiated on clopidogrel. So I think that it's fair to say that antiplatelet therapy with either aspirin monotherapy or clopidogrel monotherapy would be considered safe. However, using any combination of the two or dipyridamole monotherapy is not represented in this data adequately.
This is Devin Holden. Just a quick question. Did the outcome of not seeing any decreased risk of occlusive events surprise you based on the previous literature, and any thoughts about why that might have been? Like, was there a difference in baseline risks between the groups as far as risk of a vascular event or anything like that?
There was no data mentioned on the baseline risk between the two groups. It did surprise me based off of the previous data that there was no decreased risk in occlusive events. We know that there's an increase. These patients were already on antithrombotic therapy initially, so they had some sort of an increased risk prior to their intracerebral hemorrhage. So it surprised me that they did not see a decreased risk in these occlusive events given their previous history. But again, we did not see any of the, or we didn't see any differences between the two groups in their previous risk.
CJ, this is Colleen. I'm curious, did they mention anything more specifically about when those agents were restarted? I noticed in your slides it said beyond 30 days after intracranial hemorrhage, but did they give you any more specific information about when those agents were restarted, if it was greater than 30 days?
They did not give any information on if it was started greater than 30 days. I think that's one of the big limitations of this study as well, is that we don't know exactly when that initiation was started. And that could have been a difference between the avoid and the start group that might have been a reason as to why we didn't see a difference in reduction of occlusive events. They could have just been not started as quickly as the patients that would have been restarted maybe at the 7 days mark or the 10-day mark. So I think that further studies need to evaluate more temporally when the most appropriate time is to restart these agents.
Thank you, CJ. Are there any other questions for CJ? Okay, I don't see anything else in the chat. So great job, both CJ and Sarah. And thank you everyone for joining our Journal Club discussion today. Remember to follow Twitter for all of the tweets related to this topic. Thank you and have a great day.